Hello, my name is Ravi Vij. I'm from My Cancer Haven, and I have today with me the Dr. Ola Landgren, who's a professor of medicine, chief of the division of myeloma at the Sylvester Cancer Center. He's endowed chair in immunotherapy at the organization, and he's going to talk to us today about multiple myeloma. Abstract that he presented at the ASCO meeting that got a lot of traction. So welcome, Ola.
Thank you very much, Ravi, for having me. It's really a great honor working with you always. Thank you.
So this abstract was a randomized study of Kyprolis, lenalidomide, dexamethasone with or without daratumumab, done at a number of centers, but I believe that you were the investigator that put the trial together.
That is correct. This is a randomized multi-center study comparing the three-drug combination carfilzomib, lenalidomide, dexamethasone to the four-drug combination Darzalex with carfilzomib, lenalidomide, dexamethasone. It's an investigator-initiated study, and I was the writer of this protocol. And we open it, and it has 7 sites. So it's here at the University of Miami, being the lead site. I am the lead principal investigator. It is also open at Sloan Kettering in New York, at MD Anderson in Houston, Texas, and Moffitt Cancer Center in Tampa. We also had Huntsman Cancer Center in Utah, Roswell Park, also in New York, and Stony Brook, also in New York. So 7 centers have contributed enrolling patients and following patients on this study.
Kudos to you to be able to get such illustrious centers together for the research, which clearly is very important, and that's why they committed to it. So just to lay the background, what is the background in which this study was conducted, and what were your goals?
Well, we have seen in many studies how the use of modern combination therapy in newly diagnosed patients with multiple myeloma can deliver deep and durable responses. And this has been reflected in MRD negativity. And I think what we have seen increasingly over the past 24 months, that this is true independent of patients' transplant eligibility, meaning that patients are both transplant eligible or transplant ineligible. You can see the same thing if you use modern combination therapy. And as you know, I was pioneering the work on minimal residual disease as an early endpoint for drug approval in myeloma. And I started that work when I was at the NCI back in 2009. And we worked for 15 years. And last year we were invited to ODAC, the Oncology Drug Advisory Committee for the FDA, and presenting for ODAC. And there was also the I2 team that worked in parallel with us. And we together presented to ODAC, and they voted 12-0 in favor for MRD as an early endpoint for accelerated drug approval. And this really, I think, is a huge step forward for the field because we can get drugs approved much faster. We don't have to wait for 10 or 15 years for data set to mature. You can, about 1 year after randomization, see if there is more MRD negativity on the experimental arm, and that could give a drug or a combination of therapy an accelerated approval. You still have to collect the progression-free and the overall survival to prove to the FDA that there is a superior progression-free survival to obtain the full approval. I think from a study design perspective, this opens up a completely new avenue to develop studies independent of transplant eligibility. And that's exactly what this advanced study is doing.
Yeah, I think do need to give due credit, acknowledgement to you and all your efforts over the years, right from the NCI to Memorial Sloan Kettering, and now at Sylvester. You've been pursuing MRD and have been a pioneer and a thought leader. And hopefully the FDA will come around to the ODAC committee's recommendations to accept MRD as a surrogate endpoint. So thank you for all that you've done there. So in this particular study, can you tell us what the trial design was?
Yeah, so as I mentioned, this is a randomized multi-center study with the 7 sites I mentioned. And I mentioned the 3-drug versus the 4-drug being compared head-to-head. So it's a 1-to-1 randomization. And here on this slide, you can see how in blue, the daratumumab plus KRD is given for 4 cycles. and patients that are transplant eligible can collect their stem cells and then receive additional 4 cycles. In gray under, you see if you're randomized to K/D regimen, you get 4 cycles, you collect stem cells if you're a candidate for collection, and then you get another 4 cycles. And then as the next step, it says the risk-adapted consolidation. Now we are testing for MRD negativity. So this is done after 8 completed cycles. And patients are tested with the adaptive biotech, the only FDA-cleared technology to determine MRD status for myeloma at this time. So patients that are 10 to minus 5 negative, they would be going to the next step, which is the maintenance that offers lenalidomide. And the study initiated in 2020. So that was the standard of care and has been the standard of care and is still the only category 1 standard of care, although we have a lot of new maintenance regimens that have evolved over time. For patients that are MRD positive, they were recommended to go to a autologous stem cell transplant as the next step and then go to maintenance. For patients that enrolled on the study that were not transplant candidates, they obviously didn't have any stem cells, and they could then go straight to maintenance. So that's the study design.
I think you've talked to the contents of this slide, but would you like to expand anything on the patients enrolled?
I think there are, as always, a lot of practical details, and I think we know clinical medicine. You can look in a cookbook, you can download some of these simple guidelines that are online. But when it comes to delivering care, it's a lot of detail and experience. So some of those details I want to share with people that treat patients that may not be completely familiar. Details I think are very important. Number 1 is that carfilzomib was given once a week. We would not give it twice a week. And we gave it 20 milligram per meter square, the first cycle, the first dose, and the second and the third dose of that first cycle was 56 milligrams per meter square. Thereafter, it was 56 milligrams per meter square for both cycle 2, day 1, 8, and 15, and that was true for cycle 3, 4, all the way up to cycle 8. The second very important aspect is that we gave minimal IV fluids. You have seen in older papers, older studies, carfilzomib has been blamed for causing a lot of congestive heart failure. I would say that a lot of that is due to excess fluid. So if you give half a liter of fluid before and after, which many studies have done, many patients will develop congestive heart failure. In particular, if you treat patients that are, say, 60 or 65 years or older. We did not do that here. We gave 250 milliliter of IV fluid, and that was only given cycle 1, day 1, 8, and 15. And thereafter, all the IV fluid was stopped. Also, very importantly, the guidelines to prevent blood clots with myeloma therapy for years has been stating that you can use aspirin. But we have seen if you use these powerful combinations that you see a lot of DVTs, and it can even lead to pulmonary embolism or PE. So therefore, we use oral factor 10A inhibitor therapy, which is really critical to do. So, for example, we gave rivaroxaban 10 milligram once a day. And with that, you don't see DVTs or PEs. And lastly, I also want to say that part of the workup for the enrollment of the study was to evaluate the patient for frailty, to make sure they don't have an underlying cardiovascular disease, and also to do an EKG and an echocardiogram to clear the patient. These are very important aspects. If you do it that way, this is an extremely safe therapy. I already pointed out that stem cell collection was encouraged after 4 cycles for eligible patients. I also pointed out that after 8 cycles, MRD testing was done. And I mentioned also that transplant was recommended for those patients who are MRD positive after 8 cycles, while for those that were MRD negative, the transplant was deferred by the design.
So what was the population of patients accrued?
Well, here you have a breakdown from the demographics overview between the 2 arms. I think some of the high points are that the average age is around 60 years. You can see there are slightly more males in the study. You can also see that the performance score, the patient's wellness factor, if you want, is 0 to 1 for the majority of patients. This is similar to what we see in most studies for this indication of newly diagnosed patients. There is a distribution of different ethnicities and races, and you also see that the majority of patients are the International Staging System, or ISS 1 and 2, which is what you see in most studies. I also want to highlight that about a third of the patients are labeled as high risk with cytogenetics, the traditional factors. There's actually a slightly higher rate of patients being high risk in the 4-drug combination. So the daratumumab KRd arm has 36, and the KRd arm has about 30% of patients being high risk. I think in summary, we conclude that the two study arms are very well balanced.
And it seems like you did hit your primary endpoint and with impressive results.
The primary endpoint was to look for MRD negativity 10 to minus 5 by next-gen sequencing after 8 cycles in the intention to treat population. And as you see on this slide, yes, it's highly significantly better for the Dara-KRd arm compared to the KRd arm. It's 59 versus 33%. And if you apply statistics, the odds ratio is 2.9, and the p-value, it's less than 0.0001. So this is a very, very strong result.
And what can you tell us about some of the secondary endpoints of relevance?
So the results we're looking at here come straight out of the ASCO presentation, and just a few weeks later, it was presented at the European Hematology Association, the EHA meeting in Milan in Italy. The full publication at this time has not been published, and we are working to put all the details together. For the presentations at ASCO and EHA, we wanted to shed light on the populations that are younger and older as some form of a surrogate endpoint for transplant-eligible patients. So we have obviously all the information on who were transplanted or not, and if they collected stem cells or not, but we didn't have all the data put together from all the sites for ASCO and EHA, so we didn't want to provide non-complete data, but that will be in the full publication. But for the presentation here, we're looking at, and from ASCO and EHA, we use the age midpoint around 60 years as a surrogate. And as you can see here, for patients below the age of 60 and for patients 60 years or older, the Dara-KRd regimen is significantly better in both groups. We also used other cutoffs. So we used 65 years in the sub-analysis, and you see the same thing. But because there are fewer patients from 65 up to 75, which is the upper cutoff for the enrollment of the study, you don't have significance there. So we use the midpoint, which is 60, but I think this is very, very encouraging.
What about by risk factors?
Here, I think very important, Ravi. I think, first of all, if you look here, you see that the delta, the improvement, if you want, in the high-risk patients, it's about 20%. And you also see that in the standard risk patients, the improvement is about 30%. So looking at these numbers, the addition of daratumumab is better in both the groups. And I think for a long time, you and I have been in the field for a long time. People have talked about these so-called risk-adapted therapies, but people have said, give the best therapy to the patient with high risk. My argument and our argument for the entire study is, yes, the high-risk patients, they need the better therapy. But look at the standard risk patients. That's why you see the greatest improvement. If you have a good therapy, it will always work the best in patients that have standard risk disease. So I think that the idea of so-called risk-adapted therapy is probably flawed. I think it's much better if you want to optimize outcome for every patient, give the best therapy to every patient. And that's what the data shows. You have it here right in front of you.
That's certainly convincing there. What about progression-free survival?
Yeah, the study showed that at almost 3 years of follow-up, amazingly, the Dara-KRd regimen has 92% of the patients free from progressive disease. That's a very strong result. At 3 years almost of follow-up, 92% of the patients are free from progression. And then you see for the KRd is 83%. That's also very good. You see how the curves are separating. You see the p-value is 0.1400. So it's not yet significant, but the follow-up is 31.2 months. Given what I started off talking about, how we work with the FDA for all these years, showing that MRD is a very strong predictor for progression-free survival, and therefore they have already implemented it as an early endpoint for accelerated approval. Our expectation is that these data are going to mirror that exact pattern. So I would think with longer follow-up, we're going to reach significance, but we obviously have to wait to see till we have the data. But this looks very, very, very encouraging, and I think this is a very, very clinically relevant regimen.
And also for event-free survival?
Yeah, so in myeloma, for a long time, overall survival was the endpoint because there were really no good therapies. And then progression-free survival became the endpoint over 20 years ago. And in 2024, MRD negativity became the endpoint for accelerated approval. So what we wanted to shed light on here is if you think about where the field is going, I think more and more physicians, in particular here in the United States, are changing the therapy for patients, although they don't formally meet the criteria for progression. And we have seen that for a long time. You and I have seen that in our clinics, and I think we see in referrals all over the country that doctors are changing therapy because there's a little deviation of some of the markers in the blood or some other thing. The patient do not formally meet progression criteria. So in this analysis, what we did, we captured event-free survival. That's not yet in the myeloma literature to a high degree. So an event could be death, it could be progression, but it could also be change of therapy. So for example, someone could transplant the patient, although the patient was MRD negative. That's not what the protocol called for. Or there could be some other change in the therapy. And I think with blood-based MRD tests becoming available in the field, we're going to see much, much more of this in the field. And I think this is something we really need to take into account. So that's why we want to just shed light on this in the presentation.
And how was the therapy tolerated?
Well, I think that overall, I mentioned this was a very well-tolerated therapy. As you can see here, the safety data is consistent with the established safety profile for each of the individual drugs. And also, overall, the two study arms have very comparable rates of treatment-associated adverse events. I think it boils down to being experienced, knowing what the details are. I think the initial workup I mentioned, patient could not go on if they are frail, if they have underlying cardiovascular disease. Echo and EKG is done on every patient. And also, I mentioned how we give the therapies. We give once a week of carfilzomib. We give the maximum doses 56 milligrams per meter square. We would not use 70 milligrams per meter square. That's not how the protocol is written. The minimal fluid with 250 milliliter saline only before the first doses in the first cycle, and also the oral factor 10A inhibitor therapy with rivaroxaban 10 milligram. I think these are the very important components. These are the secret sauce also to deliver a very safe therapy.
And anything else you wish to add on the safety profile from this slide?
Well, I think it's important, of course, always in every study to look for the safety. That's the number one thing I always look for, and I'm sure you do the same. So I was very happy to see that the safety data for the purpose of serious adverse events also is consistent with the established safety profile for each of the individual drugs. There's really no alarm here. Sadly, there are two patients that have passed away on the Dara-KRd arm, and both of these were due to sepsis. And there was also one death on the KRd arm. This was due to progressive disease. We have treated over 300 patients, and myeloma sometimes can be a very aggressive disease. So unfortunately, we can see this in our standard of care situation as well. Overall, the two study arms had comparable rates of treatment-associated serious adverse events. And you can see on the left that there is really no alarm here. It all comes back to what I talked about, knowing the details for how to treat the patients.
So what are your key takeaways for the audience?
Well, number one, the primary endpoint of MRD negativity 10 to minus 5 by next generation sequencing in the intention to treat population was higher in the daratumumab KRd arm compared to the KRd arm. 59 versus 33%, odds ratio of 2.9, highly significant with a p-value less than 0.0001. Number two, at almost 3 years of follow-up, on the Dara-KRd arm, 92% of the patients are free from progression. This is a very impressive result. For KRd, it's 83%. That's also very impressive. And we see here how the p-value is a trend for significance. It's 0.1400. We expect with longer follow-up that this will be significant, but people obviously need to have to wait for the results to come back. There is no new safety concern with the study as we have looked through together. And thirdly, we conclude, based on all these observations from the standpoint of the efficacy and safety, that Dara-KRd should be a new standard for newly diagnosed multiple myeloma patients that are receiving initial KRd backbone therapy. And this is independent of transplant eligibility. So these are our deliverables.
So where do you intend to take this further?
Well, as I mentioned, the ADVANCE clinical trial is an investigator-initiated, randomized, multi-center study for newly diagnosed patients with multiple myeloma. Because it's an investigator-initiated study, it also has a strong focus on translational research assays. So we and other groups are asking questions such as, how does it work? Why do some patients reach MRD negativity and they sustain MRD negativity, while some patients may not do that? What is the interaction between the disease biology and the given drugs? What's the interaction between the disease biology and transplantation? What's the interaction between the disease biology and the immunotherapy? What role does the immune system play? So in order to capture this, we have collected very many samples at all these different time points, bone marrow biopsies and blood work over time. And we are just about to go into the next phase where we are doing whole genome and whole exome sequencing, single cell sequencing. We're doing multi-omic approaches, protein assays with mass spec. We have also flow assays and many other approaches as well. And we would love to collaborate with other groups. So other groups that have other ideas. The consent allows us to develop biomarkers, and we have many patients. There are over 300 patients with long-term follow-up on this study. But I also think that another deliverable here is that we have already worked on a new investigator-initiated ADVANCE 2.0 study. And here we're using a bispecific antibody, BCMA CD3 targeted antibody, elranatamab. And this is in combination with KRd or lenalidomide dex. And this actually is already in the clinicaltrials.gov. You have the NCT number here, and it's just about to open for enrollment for newly diagnosed patients with multiple myeloma. So that's the next step forward.
Look forward to obviously that trial. It'll take a little while, and then have you back to present the results of that study in the future. One of the things before we wrap up is going to be just a question that I know you've been a proponent of Kyprolis instead of Velcade in frontline regimens. Do you use much of the Dara-VRd or the isatuximab VRd regimen at all?
Well, before I answer the question, I want to say I have absolutely no intention whatsoever to tell anyone else what to do. I can share with you what we do, and I answer your question. We use mostly the Dara-KRd regimen because it is a very effective therapy, has no neuropathy, no peripheral neuropathy. With Velcade, we see that in 50% of patients. That's what the literature shows also. But we also recognize that Kyprolis is not the right drug for a frail patient, a patient with cardiovascular disease. And we also know that if you give aspirin as an anticoagulation medication, you're going to run into a lot of DVTs and PEs. The IV fluid is one of the main causes for congestive heart failure. So therefore, we have really been conservative with IV fluid. So we do optimized IV protocol for fluid. We check every patient for cardiovascular, and we do the oral factor Xa inhibition. So therefore, Dara-KRd has become our standard of care. And for patients that are not candidates for quadruple therapy, we would use a lot of Dara-RD. There are some patients that have more of a high-risk disease biology where we think that the Dara-RD may not be sufficient, but they are not candidates for the Kyprolis-based therapy based on the reasons I mentioned. For those patients, we would do the Dara-VRd. But other than that, those other options are our main options.
Thank you very much for this enlightening discussion, and I look forward to hopefully having you back for another presentation in the future.
Thank you very much for having me, Ravi. It's
Thank
really
you.
a pleasure. Thank you.